Uh, oh, recording started. So in the facial pains, one thing is very important is that the superficial branches, for example, the supraorbital, for example, the infraorbital or the mental nerve, they can be easily blocked with the help of ultrasound. But where it goes to the deeper blocks like ultrasound and maxillary or mandibular, definitely studies are there. Researchers have blocked them with the ultrasound guidance, but the accuracy is definitely at the tip. Ultrasound cannot show you with a great accuracy. That is one of the problems with the ultrasound for the superficial structures. It is superb for temporomandibular joint. It is very, very good. But if you think of the for the temporal mandibular joint, it is very, very good. But if you think of the deeper blocks like the maxillary or the mandibular divisions, in those cases, it is better to couple with the fluoroscopy because I will show you the studies and the meta-analysis of those studies also. But the success rate varies a lot. Okay, so let's start with the ultrasound guided procedures for the facial pain. So first of all, the face mainly supplied by the branches of the trigeminal. Trigeminal divides into its three branches, that is ophthalmic, maxillary and mandibular. Ophthalmic supplies the upper part of the face, mainly above the nose, the eyes, the forehead and the upper part of the anterior part of the scalp as well. The whole thing is supplied by the nerves from the ophthalmic division of the trigeminal nerve, whereas the maxillary division supplies the middle portion which remains close to the maxilla. So it extends up to the lower palpebral fissure or the lower eyelid also, and last but not the least is the mandibular nerve which supplies the lower jaw at this area. Okay, but in if we compare with the other two, that is the ophthalmic and maxillary, they do not have any motor components, whereas the mandibular division is having motor components. So there are some motor components from the main nerve trunk itself, and there are some motor components from its branches as well, anterior and posterior branches. Okay, so that is why while we are blocking the mandibular division, especially with the radio frequency, we can actually stimulate, and in those cases we can actually see that these masseter and temporalis, they are moving while we are stimulating the mandibular branch. So that is one of the big difference with the mandibular with the other two. Whereas in case of maxillary or ophthalmic, you won't be finding any motor component because it do not have any motor component. We'll be discussing the branches one by one, but first let us see the ganglia. So where the ganglion is situated. The Gasserian ganglion or trigeminal ganglion is situated in the medial cranial fossa, which remains close to the petrous part of the temporal bone. So if I say like this, it will be too much theoretical, you won't be able to understand. So let's have this model. So in this model, we'll be able to see how it looks in the middle cranial fossa and what are the foramens and everything. So in this model, you can clearly observe the brain. This fossa, cranial fossa, is divided into three portions. This is the anterior cranial fossa, this is the middle cranial fossa, this is the inferior cranial fossa. So if you see from above, so most anterior and most superior is the anterior cranial fossa, middle is at the middle portion and posterior remains at the lowest portion. So they are forming a stair steps like thing. Now, this portion, that means the anterior cranial fossa, is mainly formed by the two bones. What are those? First of all, portion from the frontal bone. Then we are having the ethmoid bone at the center, and in by the side we are having the lesser wing of the sphenoid bone. Whereas in the middle cranial fossa, we are having this is mainly the
Sir,
greater.
not visible, sir, properly.
It is not visible properly.
Yes, sir, light.
Now it is visible. I have hold it in front
Yes,
of
sir.
me.
Thank you.
Okay. So in the middle cranial fossa, you see it is mainly formed by the greater wing of the sphenoid. Posteriorly, you can see two bony bars by the sides, which is actually a part of the petrous part of the temporal bone. And Below you can see one large opening. This is the foramen magnum. I am putting a probe there, so it is the foramen magnum. So the brainstem becomes the medulla oblongata, that it comes out to this foramen. So that is how it is, the anatomy is. Now if you look at the structures from middle anterior to posterior, we have the cribriform plate and the crista galli, followed by we have the anterior clinoid process here. Then we have this depressed area, that is the sella turcica, which houses the pituitary gland. Then we have the Turkish saddle back shape, that is, this is the Turkish saddle back shape, and by both the sides you have the posterior clinoid process, and this sloping area for the midbrain and the medulla oblongata is actually the clivus. Now, clivus and pectorus, they do not fall in the same plane. Clivus is a central structure, whereas the pectoral bone are the peripheral structures. But when seen under fluoroscopy level from the lateral view, they form a clivopectoral angle. So we have to know a little bit of the anatomy, flow anatomy, everything. Now, if we look at this middle cranial fossa, one foramen is clearly being seen. So, let us show this foramen. This is from the left side and this is from the right side. So, these are the foramen oval. So, remember there are three foramens by which the branches of trigeminal nerve they goes away. But what happens actually when the foramen oval takes away the mandibular nerve, whereas this foramen rotundum, this small foramen you can see is the foramen rotundum. It takes away the maxillary nerve, and here this is the superior ophthalmic fissure. Okay, so they takes away the ophthalmic division. So mandibular, so maxillary and ophthalmic, and here lies the area for the cavernous sinus. This is the area for the cavernous sinus, and just by the side of the cavernous sinus we are having this gland as you are seeing in this picture. So this is how it looks. Now one thing is very important, that if we want to approach the branches, remember we cannot actually approach the ophthalmic division. Why? Because it is directly going to the orbit. So if I want to target the ophthalmic division, we have to puncture the globe, which is not possible. Now coming to the other two branches, what can be blocked are these two blocks, like the maxillary division and the mandibular division. Now where the maxillary division is blocked? Maxillary division is blocked after coming out from the foramen rotundum, and also mandibular division can be blocked after coming out from the foramen oval. So here there are two ways. If you are going only for the branch block, we are not intended to go inside the ganglion, whereas in fluoroscopy guided procedure our main target is the ganglion, but here in ultrasound we are mainly targeting the branches under the ultrasound guidance. Similarly, here we are trying to block at the pterygopalatine fossa. So where it lies the pterygopalatine fossa? It remains lateral to the lateral nasal wall, and here the mandibular nerve continues, okay, and they goes as the infraorbital nerve, then they comes out to the lower part of the eye as a inferior orbital nerve. So in the branch blocks we can easily block with the ultrasound guidance the infraorbital nerve. Similarly, we can block easily the supraorbital nerve, and among the branches of the mandibular division, we can block the mental nerve. Okay, so these three branches can be easily blocked. Whereas in fluoroscopy, we can actually go into the ganglion and we can block all three divisions. So definitely fluoroscopy has some edge, so it is not free from risk if you're going to the ganglion. But in a number of cases, when only one branch is involved, we actually go for the branch blocks. Let us discuss a little bit about the trigeminal neuralgia. We all know trigeminal neuralgia is a syndrome of pain which is agonizing, paroxysmal, lanceolating, and which lasts for few seconds. Okay, there could be successive attacks, but it should be within few seconds, and after that there will be a pain-free period. Remember, sometimes there could be successive attacks the pain which not allowing the patient to enjoy the pain-free period, and sometimes it can be triggered by the chewing, speaking, touching the face, etc. And even in severe cases, we have seen patients where the patient just after entering the room, they ask to switch off the fan because the ceiling fan what is moving, that is actually putting pressure over the cheek, and that is activating and triggering the pain of the trigeminal neuralgia. So it is so severe that previously people has committed suicide because of the trigeminal neuralgia. That is why it is also known as the suicidal disease. Remember, this disease description is not new because about the trigeminal neuralgia we got the reference in the literatures of the Ibn Sina, which long back then there are attempts to manage the trigeminal neuralgia by John Locke by putting sulfuric acid in the face. So there is a long history. I'm not going into that history, but ultimately success came when the Petrus in 1902 he has applied the alcohol injection in the ganglion. And in idiopathic trigeminal neuralgia, usually the neurological examination is normal, and pathophysiology, which is considered as the compression of the trigeminal nerve by blood vessel. Remember, not in every case that we are getting this aberrant blood vessel from the middle or posterior cranial artery, but sometimes there could be possible to get a blood vessel. But what it happens, there is demyelination of the trigeminal nerve followed by the ectopic impulse generation, giving rise to this type of pain. So that is what is trigeminal neuralgia. Now if you see about the epidemiology, it is more common in females. Female is to male is equal to 1.5 is to 1. Peak incidence is 50th to 17th year, and 5% patients is having the family history. Now among the divisions involved, V1 is most rarely involved, that is in 4% of the cases, whereas only V2 is involved in 17% of the cases, whereas only V3 is involving at 15% of the cases. Most of the cases what we get is about the V2 plus V3, which is about 32% cases, and all three divisions about 17% of the cases along with the V2. Whereas the V1 plus V2, V1 is comparatively rare, V1 plus V2 occurs in around 14% of the cases. Now, what you are going to ask the patient in a case of trigeminal neuralgia? First of all, does the pain occur in attacks in trigeminal neuralgia? Usually the patient says that pain comes in attacks, and most attacks are of short duration. Attacks are unilateral, and attacks occur in the region of the trigeminal nerve, and there are usually no unilateral autonomic symptoms like lacrimation, stiffness of nose, and edema, puffiness, swelling of one side. Okay, so these are usually the feature of trigeminal autonomic cephalalgias, which are usually absent in case of trigeminal neuralgia. Just 1 second. Which are usually absent in case of trigeminal neuralgia. So let us see what are we are getting to find. Neurological examination in trigeminal neuralgia. Usually all cranial nerves are normal, especially in idiopathic trigeminal neuralgia. In some cases where the trigeminal neuralgia is secondary to multiple sclerosis or by the CP angle tumors, and those cases we might found changes according to those disorders. Okay, depending on the position of the CP angle tumor, we'll find the neurological deficits accordingly. Now in the differential diagnosis, we have to differentiate with the non-specific facial pain, TMJ arthrosis, dental disorders, and sometimes the vascular migraine. Now coming to the clinical practice algorithm, usually patient with paroxysmal unilateral facial pain, all cases are seen for the MRI scan nowadays, except otherwise it is not contraindicated. And then we have to go for the differential diagnosis, because without the MRI scan we do not know what is there. Okay, sometimes even in one of my case I have found the patient is having only V2 division trigeminal neuralgia, but when we are actually going to see the MRI angio, we have found the large vertebral artery winding round around the foramen ovale. So if I have accidentally punctured that artery, it could be a dangerous condition. That is why we have to first check for the MRI scan. Now, the treatment of choice in young patient usually considered AMVD with a comparatively lower recurrence rate, and in elderly patient it is the radiofrequency of the Gasserian ganglion. Now, in cases where there are mostly ophthalmic division is involved, we can go for the balloon compression as well, because balloon compression helps in reducing the anesthesia or hyposthesia of the cornea, which sometimes be associated with the radiofrequency ablation of the ophthalmic division, leading to a exposure keratitis. Now, among the treatment options, we are having the carbamazepine. Usually, we start at the dose of the 200 milligram sustained release tablet once a day. Then gradually we increase up to 800 milligram. Now, carbamazepine, you always consider that allergy could be one contraindication for it. Sometimes there could be even and SJS or Steven Johnson syndrome reported from the carbamazepine. So while giving, be careful. Ask the patient that if you develop any rashes, you immediately stop the medications and report. Similarly, after the carbamazepine, the second choice is oxcarbazepine, which is comparatively less potent. In fact, the 100 milligram is approximately 150 milligram of oxcarbazepine equivalent to the 100 milligram of carbamazepine, and usually it is also started with a comparatively lower dose like 150 milligram once a day, and gradually it can be used up to 1800 milligram. Similarly, phenytoin and another alternative when the carbamazepine and oxcarbazepine is not tolerated by the patient, then we can go for the gabapentin or sometimes tricyclics. But remember, highest evidence is with the carbamazepine and the oxcarbazepine only. Next, coming to the baclofen. Remember, it's a muscle relaxant, centrally acting, but it has shown positive effect in trigeminal neuralgia. Usual starting dose nowadays is 10 milligram sustained release. Then gradually we increased up to 880 milligram, sometimes in divided doses, or we can go for the sustained release preparations. Okay, so usually for the better compliance, we go for the sustained release preparations rather than the giving multiple times. So these are the medications which is usually prescribed to the patient. Apart from that, the simple analgesics like paracetamol, okay, weak opioids like tramadol, they can also be used in association. Now coming to the treatment option, we are having the surgical option, that is a surgical microvascular decompression, stereotactic radiation therapy or gamma knife therapy, percutaneous balloon microcompression, percutaneous glycerol dialysis, percutaneous radiofrequency, and experimental treatment is the Gasserian ganglion stimulation, but is not routinely done. Now today's part is mainly the branch blocks. Now branch blocks are effective when only a small portion of face is affected by this neuralgia. That means when only a specific division or branch is involved. And in three areas we can easily do the branch block. One is the supraorbital, next is the infraorbital, the third one is the mental. Remember, in certain cases, these are very simple. When you are starting, you got a patient of trigeminal neuralgia and you are not confident about going for a Gasserian ganglion radiofrequency, you can actually alternatively try if the involvement in a smaller area, or in patient with the post-herpetic neuralgia involving the ophthalmic area, we can go for the supraorbital nerve block. So let us see how this ophthalmic division goes. So basically the ophthalmic division divides into its three branches while it going into the supraorbital foramen. So one is the frontal, one is the nasociliary, the third one is the lacrimal. Among the frontal, there are two branches. One is the supraorbital and the supratrochlear. Supratrochlear and supraorbital can be seen in the forehead and they can be blocked, among which supraorbital can easily be located because of the foramen. Supratrochlear usually remains slightly medial to that area. Whereas the nasociliary division gives branches to the anterior ethmoidal, posterior ethmoidal, long ciliary and the intratrochlear branches. And there is another branch which is supplied to the lacrimal gland, which is known as the lacrimal gland. So this is how the ophthalmic division goes. Before entering the superior orbital fissure, it has already been divided into three of its branches. Now, among these three, this is the ophthalmic frontal nerve, which actually divides into two branches. This is the supraorbital, this is the supratrochlear. So we can block the supraorbital division very easily because it's having a definite foramen through which it is coming. And this division is the lacrimal division, which actually gives a tweak with the zygomatico-temporal branch of the maxillary nerve and ultimately joins in the lacrimal gland. And the third division is the nasociliary nerve, which is again divided into, here you can see the supraorbital and supratrochlear. Here it is divided into long ciliary nerve, posterior ethmoidal, anterior ethmoidal, external nasal, and the infratrochlear nerve. So these are the branches that goes around the orbit of this nerve. Now it is accompanied by the associated artery. I am not going into the divisions of this artery because it is not that required, but you remember in the orbital group there are the supraorbital artery and frontal artery, which actually accompanies these two vessels. So by looking at these nerves, so that by looking at this supraorbital artery coming out to the supraorbital foramen and frontal artery, which is actually supratrochlear accompanying the supratrochlear, we can block these two divisions and it remains close to the muscle, that is the orbicularis oculi. So here in the cranium you can see the small foramen that needs to be blocked. So first we are discussing about the supraorbital nerve block. So supraorbital nerve is having the sensory area in the forehead. So it can be indicated when specially there is a pain involving the forehead. So which type of pain can be blocked? I have already told you about the trigeminal neuralgia involving a specific division. We can go for it. Post-herpetic neuralgia, we can go for it. If there is a scar neuralgia, we can go for it. If there is a repair planned there, okay, so just post the procedural pain relief, it can be blocked, like laceration repairs, okay, burns or brandishing. So in those cases we can go for the supraorbital nerve block. In fact, for chronic pain we block it for the trigeminal neuralgia, sometimes for the herpes zoster pain, and sometimes for the scar neuralgia. Remember, in post-herpetic neuralgia, though we try, but the results are not very encouraging in most of the cases. So coming to the complications, there is complications are very rarely reported, like hematoma, intravascular injection, eye globe damage or infection. But remember, as we are doing it under the ultrasound guidance, we are actually seeing the artery and we are actually seeing the nerve, so chances of these complications is very rare. And check the coagulation profile of the patient, then the chances are further less. So we have to actually search for the supraorbital area and the supraorbital notch, and we have to locate the nerve coming out and the vessel basically coming out through this foramen at the supraorbital area, and then we have to put our probe. And in this condition, as the depth is very minimal, usually it is a little bit difficult to put the needle in a uh, long axis view, or I should say it is a in plane view approach, rather than in most of the cases we sometimes have to go for the out of plane approach, and then we have to go for the stimulation and followed by local anesthetic and the radio frequency ablation to specifically block this branch in the supraorbital range. So Chinmada will show the supraorbital, then I will move to the next. Hello, hello. Your voice is not audible. Shinmada?
Yes, now I think I am audible.
Yes, now you are audible.
It's over. Now. Hmm. Okay. So I will first find the supratrochlear and supraorbital nerve. So for this reason, I will take the linear probe only. Okay, I will take the linear probe and probe. Yeah. So this is the supraorbital ridge, and this is the gap where the supraclavicular nerve is, supraorbital nerve is coming out. So here actually nerve and vessel all are together. We cannot separate every time that which one is the nerve. Okay, so there is a pulsatile artery. We have to find the pulsatile artery. So let me see that whether it takes the color or not. So first when I put the probe like this, then when I'm putting the probe like this, then I can see the cortex, bony cortex, regular bony cortex, and there is no gap. But when I come like this, then suddenly I see that there is a gap and there is a vessel pulsating. Okay, so what I am doing, I'm starting from here and I am going like this, a bit this side. I'm rotating like this. Okay, then I can find it easily. And of course, the Doppler function, I have already made it on. So you can see. So this is the gap and there is a vessel. Okay. So this is the supra orbital nerve area. Okay. This when you inject here, so as soon as I can bring it in the middle of the screen, so I know the location, and then I will go out of the plane approach. There is no need to go in plane approach. Okay, here. Okay. Same thing, this side also. If I want to see in this side, so you can see the cortex is, when I'm seeing the cortex, it is single line, and gradually when I come down, so this is the location of supraorbital nerve on this side. Okay. So this is all about it is a neurovascular bundle. We can see the vessels. Nerve is hardly seen. So when we will put for block, of course, you can give directly local anesthetic. And if you want to do in radio frequency, then put the radio frequency needle, and with sensory stimulation, you can locate the nerve. Okay. But this is the location of the supraorbital foramen. Okay. Okay.
So next we'll be moving for the next block, that is the maxillary. Now one thing we should remember, that the maxillary nerve block is a comparatively deeper block, so we can find out the area through which we have to enter, but internally there are so many branches of the arteries, it is very difficult to specifically differentiate the internal maxillary artery, which is supposed to be differentiated when we are doing the maxillary nerve block under ultrasound guidance. Now the the maxillary division, it actually coming out through the foramen rotundum, and it comes into a space which is known as the pterygopalatine fossa. Now, if we look at the pterygopalatine fossa is the area which is located posterior to the posterior wall of the maxilla and anterior to the lateral pterygoid plate. Now, pterygoid is a part of the sphenoid bone, whereas this posterior to the maxilla, this forms a triangular opening. So, where we can see in this, where we can see this triangular opening, let's see. So here, if you look at carefully, so let's have the probe. Here it's not a model which is real because it is a little plastic model, so you will not be finding that clearly, but I will show you the area. So here, just this is the lateral pterygoid plate. Okay, so this is the, can you see this? This is the lateral pterygoid plate. And just anterior to the lateral pterygoid plate, we can see this opening. This is the opening for the pterygopalatine fossa. Now,
Dajyoti,
this is the
you,
zygomatic.
Dajyoti, you may have to stop the background blurring.
It is showing causing problem, na? Let me do one thing. Blurring is there. I don't think it is blurred much.
No. When you were showing the
Just one.
skull, then
Just
at
one.
that point.
1 second. Okay, let me do one thing because in this view we cannot go for it. Okay, I think this camera will be good. So if we look at this point, if we look at this point, now it is clear. So if we look at this point, we can see this is the lateral. I am showing it from the lateral side. So here is the lateral pterygoid plate. Okay, so this portion is the lateral pterygoid plate. It is a little bit difficult to see. This is the lateral pterygoid plate, which remains in between this U. That means this U is formed by one side coronoid, one side it is the mandibular condyle, and in between we are getting this deeper bone. And this deep bone is basically, if we see the from the infrazygomatic area, if we look at from the infrazygomatic area, we can find out this as the, I am holding my finger, so this is basically the lateral pterygoid plate. Now if we go anterior to this lateral pterygoid plate, if we go anterior to from this lateral pterygoid plate, a little bit difficult to find out this area. Now it is shown. So anterior to this lateral pterygoid plate, there is an opening that is goes into the pterygopalatine fossa. Exactly, now I am holding it in the correct way. So actually we have to go and enter to that area of the pterygopalatine fossa, and then we have to progress our needle till we reach the lateral nasal wall. Remember, it's a deep block, and I have already told you that this is not a block that is very commonly performed, and I will show you the studies and the analysis as well. Now, if you look at a little bit more about this mandibular division, so this, sorry, maxillary division, this from this maxillary division, there are small rootlets, and from this small rootlets hanging another ganglia that is known as the sphenopalatine ganglion. So basically, while you are blocking the sphenopalatine ganglia for the root of the nose pin, so and above just to it remains the maxillary division. So either we can block the maxillary division at this point, or we can go for the sphenopalatine ganglion block at the same point, but with the slight difference. One is slightly anterior, one is slightly posterior. Okay, so that is how they are situated. Now let us go for the further progression. So from this point they are giving two branches. So from their pterygopalatine fossa, it is going to the orbit as the infraorbital nerve, then it infraorbital nerve, that it continues as the this infraorbital nerve. So it is coming like this. Okay, so here there are branches which is supplying, this is the posterior alveolar, then we are having the middle and the anterior alveolar. Here it is giving the zygomaticotemporal and the zygomaticofacial branches, and this alveolus branches, that is the supplying the alveolus, is also given by this block. So it is through the inferior orbital fissure, it is becoming the inferior orbital nerve, then it comes as the through the infraorbital foramen. Okay, so that is how it comes to the lower part of the face, and these are the different branch that is given by this nerve. Okay, so while we are blocking the maxillary division, we can block either here or at this point. So in between, there is no way we can block the nerve. And now coming to the branches of the external carotid artery, that is accompanying usually the branches from this, and it also supplies the muscular branches. So you can see there are multiple branches in this area, and then they are giving the sphenopalatine arteries and the internal maxillary artery as well. So these are basically all branches from the external carotid. Now what are the indications for the maxillary division block? So first of all, it is the trigeminal neuralgia when it is involving the fetal division. The complications include cephalalgia. Sometimes there could be accidentally accidentally block the branches from the facial, then it can cause the facial paralysis. Then trismus hematoma formation, that can be possible. Now these are the meta-analysis which is performed in 2020, and there are the studies which have been performed. You see, the number of samples that is taken, or the number of patients taken in most of the studies, is very limited. Okay, so sometimes there is a case study, there are few cases of the 10 to 15 cases. In some cases they have given below the zygomatic, sometimes they have done above the zygomatic, and some studies are there which are actually cadaveric study. So ultimately the results are good, but again the number of this studies are very limited. Okay, so in all those they have concluded that the approaches to the ultrasound guided maxillary nerve block via the pterygopalatine fossa have been successfully described, but not without challenges, with its unique challenges. Like ultrasound offers significant safety and efficacy and advantages related to the real-time visualization of the vasculature, soft tissue along with the needle advancement, as opposed to the standard fluoroscopic guided approach. But there are challenges in the ultrasound guided approach as well. So the structures are deep. Usually visualization is very challenging, and sometimes it can be obscure at times. Okay, the ideal approach is yet to be determined and must be further explored. So that was the conclusion from that meta-analysis. So definitely here, like other blocks where we are usually recommending this, go for this block, that we are doing, still for this blocks we are following the fluoroscopic guided approach. Definitely fluoroscopic guided approach are not every time safe, because there also we cannot see the vessels. Here also we cannot see the vessels clearly, but in fluoroscopic guided approach at least we have the contrast agent to find out whether we are injecting anything intravascular or not, which is actually absent. And in the deep also we can see whether the needle tip is in correct position or not, which is again in ultrasound guidance is having one of the disadvantage. Usually in ultrasound guided maxillary block, the transducer is placed in the infrazygomatic area. Most of the studies are performed to the infrazygomatic area, and actually the U, as I have shown, in between the condyle and the this UVAC, basically the coronoid process and the condyle, and then with 45-degree angle both frontal and horizontal plane, it is usually forwarded, and the probe location allows the visualization of the pterygopalatine fossa. And remember, it is very limited anteriorly by the maxilla and posteriorly by the greater wing of the sphenoid. So actually we have to go in between the lateral pterygoid plate and in between the posterior part of the maxilla, and needle is advanced usually with the out of plane approach, because in this point it is very difficult to make it in plane, and under the real-time ultrasound guidance it has allowed direct localization of the internal maxillary artery, though truly speaking in my experience I am not able to clearly see it properly because it is so deep, and especially if the patient is thick, it is very difficult. Okay, and identification of the needle tip is sometimes out of plane approach is very difficult, and spread of the local anesthetic solution within the pterygopalatal fossa. Sometimes we can see, but not in all cases. Next comes the branch block. This block is definitely advantageous under ultrasound if you compare with the fluoroscopy. That is the infraorbital nerve block. That is the infraorbital foramen can be visualized just below the orbit with the ultrasound probe placed horizontally and vertically in the sagittal plane, and with fine translational movement from the medial to lateral along with the lower orbital margin, we can actually find out the bony gap in between. Along with, we can actually go for the branch block. So next we'll be seeing these two branches, then we'll be going for the mandibular division block. Okay, so let us go for the blocking the maxillary and the mandibular division.
Okay. So okay. So here I think I am audible, isn't it?
Yes, audible. Clearly audible.
Audible, no? Okay. So here you see this is a skeleton. Okay, this is a skull. Okay. So if I match with the volunteer this skull, then what I am seeing here, this is the lateral pterygoid plate. This is the lateral pterygoid plate, and this is the maxilla. Maxilla. So posterior part of the maxilla. Okay, so this is the maxilla. So posterior part of the maxilla and the lateral pterygoid plate. This two is forming a door here. Okay, through this door, of course, we will see the maxillary. This is the entry point through the pterygopalatine fossa, and for this is for maxillary branch, maxillary nerve. And if we go just below that here in this area, so this area is for mandibular branch, this area, when it is posterior to the pterygoid plate. Why this is for mandibular branch? You can see if I just make it like that, then this is the foramen oval. From foramen oval, so the nerve, mandibular nerve coming straight, so it is just posterior to that. So our target is to hit the pterygoid plate and then come posteriorly for mandibular, anteriorly for maxillary, anteriorly, and of course a bit superiorly also. So this is like with ultrasound what we can see. Now here if I put my two fingers in the as the mandible has condylar process and coronoid process. So think my two fingers, this one is condylar process and this one is coronoid process. So when I will put the ultrasound probe here, at one point I will see I will see three bony structure. One is condylar process, one is coronoid process, and third one is here maxilla, part of maxilla. Okay, I will not see this zygomatic bone because I will hold the probe under zygomatic bone. Under zygomatic bone, so three things I will see, three bony process. One condylar, coronoid, and this third one is your maxilla, maxillary bone. Okay, maxillary bone. So our aim sometimes is to see between these two, and sometimes is to see between these two. Okay, and why we want to see between these two landmarks between coronoid and maxillary bone, so that through this, when ultrasound beam passes, we can see this pterygoid plate, and if within 1 2, that is also for this pterygoid plate. So if I see between 1 and 2 and I see pterygoid plate, so just posterior to the pterygoid plate, that will be maxillary, mandibular branch. And if I see these two and I hit the pterygoid plate and I go anteriorly, I will go for maxillary branch. Understood? So these three things we will see. First, I will put the probe here in this area. So in this area, when I will prove, so what will happen? I will see the full bony structure. Then I will go a bit up, a bit up. So I will see there is a gap between these two process, one condylar and one coronoid. These two gap, and then when I will come anteriorly, I will see another gap. So understand this gap is for between two condylar and coronoid process, and this gap is for coronoid and maxillary bone. Okay, and our intention to see these gaps to see the lateral pterygoid plate in deeper plane, and lateral pterygoid plate we want to see so that we can go posterior or anterior to the plate to find both the nerves. Okay, so now see. Oh, last time when I showed you, just a minute, stop here. I showed you the supraorbital nerve. Was it showing correctly, or this type of picture was coming? Half picture. No, I'm just a minute. See, profile. What is this? Okay. Now, preview. Share. I think last time also picture was not correct. Nobody told me that, so I didn't understand. Anyway, so annotate. Okay. So now you see. So here, this probe is for to be used. This is the curvilinear probe. For any deeper structure, we will see with the curvilinear probe. Okay. So now what I will do, I can palpate the zygomatic process. So I am not going over the zygomatic process. I will go below the zygomatic process. So this area below the zygomatic process is mainly the mandible. First, I will see the mandible. So just a minute. So this is the mandibular ramus. So you can see this is the mandibular ramus. Which one is mandibular ramus? This one. This one is mandibular ramus. Okay. So if I go a bit up, so you can see two parts of the ramus. That is the when you see the gap, I mean gap forming between the two condylar process. This is condylar process. This is coronoid process. Okay. And below I come, so this is the ramus of the mandible. Okay, ramus of the mandible. When I go a bit up, then this is the condylar process, coronoid process. So between this, when I see through this, then also I will be able to see this is the pterygoid plate. But if I go a bit anteriorly, then I will see coronoid. So this one, then it is the coronoid process, and this part is maxilla. This part is maxilla, and this part is your this is the pterygoid plate. This part is pterygoid plate. Okay. So remember, first step to see the ramus of the mandible. Second step, make that two. One is condylar process, one is coronoid process. Third step, just go forward and see the between the condylar coronoid process and maxillary wall. Okay. So at this point, if I increase the depth a bit,
Sir, can you label them?
okay, I will label, but you try to see this area. Okay, see this area. So something pulsatile, whether you can find it or not. This is the pulsatile area. So remember, first, so this is the condylar process, this is coronoid process. Okay, and this part is your this one, pterygoid plate, lateral pterygoid plate. Maxilla here, maxillary bone is a bit, since it is not straight, so it doesn't give a periosteal shadow like this. So it is like this. Okay, this I mean ultrasound beam is not passing through the periosteum, through the bone. That's why. So this is the maxilla part. This is the maxilla. Okay, this is the coronoid, and this is the condylar. Okay, condylar. So here the procedure is basically assisted, ultrasound assisted. This part is the lateral pterygoid plate. If we see by this side, then also we are seeing this bony area. If we see by this side, then also we are seeing this bony area. If we go anterior to that, so this side is anterior, you can understand this is maxilla, and this side is posterior. Okay, so if we go posterior to that, we go for mandibular branch, and if we go anterior to that, then we go for maxillary branch. Okay, understand the concept. So these three bony structure, this is the pterygoid plate. Either you go posterior or you go anterior after hitting. Okay, and under ultrasound, only a pulsatile structure we will be able to see here, and if we see very carefully, then here also. So these pulsatile structures are nothing but neurovascular bundle with the maxillary and mandibular branch both. Okay, I show you again. Every time this doesn't take color. So here you see.
Sir,
So
if
yeah.
we go posterior and anterior, you are saying that adjacent to the pterygoid plate, these are neurovascular bundles. Even we have to hit them, or
No, neurovascular bundle, you will not be puncturing. That is not your aim, of course. But then just by the side of the vessel, there is the nerve. Okay, so you can match with this. As I told you, this picture, that these two are these two processes. Okay,
yes, sir.
so
Yes.
either we see by these two process or by coronoid and maxilla. This is the maxilla. So this
Yes,
one
sir.
is not giving the shadow of periosteum. Then also we are seeing this plate. This plate, either we go posterior or go anterior to this plate. Okay.
We will hit the bundle now, sir, because you are saying adjacent to the plate, there are neurovascular bundles, sir.
Yes. Neurovascular bundle you will of course hit, but I mean there is no other way. I mean it is very much vascular, so there is a chance that you can puncture the vascular structure. This is possible, but we will go with stimulating, isn't it? So
Yes, sir.
as soon as our stimulation becomes positive, we will not go for puncturing. We will be happy with that. So this one. So this one is the ramus of the mandible. Now this has become two. Okay, two. Coronoid and this is condylar process, this is coronoid process. So we can see from here also this part is the your pterygoid plate. Okay, so this part is the pterygoid plate, and we can see from this side also. If we go a bit high up this side, so this side also, when we go, we can hit the pterygoid plate here. This is the pterygoid plate. Okay, this is the pterygoid plate. Here some vessels are there. directly we cannot see, but we can, it can be a assisted thing. So with this picture, we know how much depth is there for pterygoid plate to hit. So you can see it is like, so it is 4.5 centimeter like that. Okay. Yeah. So between these two, clearly, okay. So this is one vessel. Can you see this vessel? So this vessel is going behind pterygoid plate. So this is associated with the mandibular branch. This is the mandibular branch associated with that. Okay. If I can put. So we can see that it is pulsating, but directly every time color it will take, it is not like that, but we can see. Okay. So here you can see up to this much only. These are assisted, I mean, procedures. Directly you will not be able to see the nerves. Okay.
Dr. Roy,
Yes, yes. Please tell me.
what if we hit these vessels? Is it we will have major bleeding or something,
No.
real complication?
No. We whenever we do this procedure, we hit many times. There is a bleeding. There is a small hematoma, chick swelling. So we tell the patient to put ice and
Nothing major.
nothing big. These are only thing is that these vessels are not very small, a bit bigger. So while injecting, you aspirate, and if something is coming, don't give particulate steroid or something, anything like that.
Yes,
Even
for
not,
sure.
yeah, alcohol, phenol. We are using phenol most of the time here, so you should not inject phenol inside the vessel. That's it.
Okay, thank you.
And check the coagulation profile as well before. Coagulation profile and platelet function. That should be normal. Okay, let's continue. So we have a very small area which is left. Replace current share. Now coming to the mandibular division. So mandibular division is already described, but remember mandibular is also having multiple branches. So mainly it is having an anterior and posterior division. The first branch is the nervus spinosus, which goes back to the cranium through the foramen spinosum, which remains very close to the foramen oval. Then we have the motor branches from the trunk, which is supplying the medial pterygoid, tensor tympani, tensor veli palatini, and from the posterior division, it is mostly sensory division, except for the nerve to mylohyoid and anterior belly of digastric. They are mostly all sensory nerves like the auriculotemporal nerve, incisors nerve, mental nerve, inferior alveolar nerve, lingual nerve, whereas the anterior division except the buccal nerve all are motor, among which the lateral pterygoid, temporalis and masseter, these are the important divisions which is supplied by the mandibular division. So that is why during the mandibular nerve block we can actually see the contraction of this, especially the temporalis and the masseter muscle. So these are all branches which are coming from the mandibular division. Now blocking the mandibular division is not difficult. It is actually the same as we are doing the maxillary division. Instead of going anterior to it, we have to go posterior to it, and then we have to stimulate. And as we have the motor branches, so usually we can get a good stimulation in most of the cases. Now there is a small branch which is known as the mental nerve, which is coming out to the mental foramen, and this nerve can also be blocked if there is a localized disease. So and the indications for the mandibular division block are the trigeminal neuralgia, postherpetic neuralgia, and sometimes in the cases of cancer pain. Complications include inadvertent intravascular injection, persistent paresthesia, infection, and hematoma formation. Mental nerve or the mental division is localized using a transverse or sagittal plane with dynamic scanning between the upper and lower borders of the mandible, and that can also be blocked. Chinmada, please show the mental nerve, then we'll go for the TMJ.
No, I did not show even infraorbital orbital also.
Infraorbital is also not shown, na? So you showed both, because these three superficial nerves can be reliably blocked with the help of the ultrasound. The supraorbital, infraorbital, and the mental nerve.
Hmm. So, I think you saw the supraorbital also at that time. I don't know whether you saw it correctly or not, because my screen was not good. So I'm just showing again. So supraorbital means first I will be on the bone, okay, and then just I will rotate like this, okay. So this is on the bone, and I will just come like this. It is too. Okay. Okay. So this is the supraorbital area. And I think all of you can see the vessel also. Yeah, this one. So just beside that, maybe this is the nerve, but I don't know. So this is the supraorbital area. Okay. Now I will show you the infraorbital. So infraorbital also the same thing. There is nothing very big here. Only. So this is the infraorbital vessel. Yes. So if you go a bit down, it is all about bone. And when we are just coming towards the eye, just in the lower border towards the eye, we will find this gap. Yes. This is the infraorbital foramen. So here, of course, we will go with the in-plane approach or out-of-plane approach. Both we can do here.
We inject beside the artery.
What?
We inject beside the artery.
Inside, yeah. In the foramen. Actually,
In the foramen.
Yeah, in the foramen, when you put the needle, you are always touching the bone, either this border or that border. I mean, ultimately, you will touch the bone, and
what
just at the foramen only will inject. Okay.
and
So
what
this
volume shall we put?
what?
What volume? 2 ml, 3 ml?
1 ml. 1 ml is sufficient.
Okay, thanks.
Then comes mental nerve. Mental nerve remains a bit difficult for old people. Young people, it is tough. It is easy. Yeah, where is the location? Location is like we know incisor, canine, premolar, molar. Incisor 2, canine 1, premolar 2, and molar 3. So it is after it is between premolar 1 and 2. So first three teeths you have to first three teeths are incisor and canine. After that premolar 1 and 2, in front of them this foramen is there, mental foramen. But in young it is very easy, but in old it happens that it goes gradually up. It goes up and so you may not be and goes towards the upper margin. I mean, in the gingival margin. So then it becomes a bit tough to get that. So here it is here. When you are just so here the formula is same. First you see the bony margin from the very lower margin, very lower end. From the very lower end you see the margin, and then you just go up, and suddenly you will feel that there is a gap. So this one is the gap. Okay. So I will make it a bit bigger. So this one is the gap. Sometimes you will of course see vessel and sometimes not. So this one is the vessel, mental foramen, mental vessel. Okay. So you can bring it in the middle part of the screen. Where it is gone. Now I was seeing and now it is again. Okay. Anyway, so this is again the lower margin, lower margin, lower margin. So this one. This one. So there is a very small foramen, and here also actually after locating it, you go with the, I mean, out of the foramen you can go, and it is always from lateral to medial. Okay, injection should be lateral to medial, otherwise you will not enter in the foramen. So this one, because opening is towards lateral side. This one, okay. Sometimes this blood pulse is not coming anyway. So you have seen, I feel. So this is the mental foramen. Any question here? Yes. Devjyoti?
Hello.
Hmm.
So we'll be going for the last part of it. So it is basically the TMJ arthrosis. Remember, this is another condition, but actually this sometimes may be associated with the trigeminal neuralgia. In fact, in one of my patients, I have found that there was trigeminal neuralgia. We have treated it, but when the pain is over, then still the patient is having problem because of the TMJ arthrosis. And sometimes it could be an independent diagnosis, sometimes may be confused with the trigeminal neuralgia as well. So it's a differential diagnosis for the trigeminal neuralgia. So TMJ arthropathy is mainly involving the dysfunction of the temporomandibular joint and sometimes the pathology of it as well. And one of the major common cause of the temporomandibular joint disorder is causing the jaw pain. But one thing you should be very careful, but to differentiate from it from the trigeminal neuralgia, few points are very much effective. Number one, definitely the temporomandibular joint is a joint pain, so it's a mainly nociceptive pain which due to chronicity can take the chronic neuropathic spectrum, but in most of the cases it is purely nociceptive pain rather than a neuropathic pain, especially in early stage. And patient often experience pain, joint and joint locking, and sometimes there is a sound while opening and closing the mouth, and sometimes there could be restricted mouth opening because of the TMJ disorder. And it is unique because of its dual function and anatomical complexity. TMJ mainly consists of the mandibular condyle, articular disc, and the temporal bone. It allows hinge and gliding movements and muscles of mastication, including the masseter temporalis pterygoid. They are very close to it. And at articular disc divides the joint into upper and lower compartments to facilitate the complex movements of the temporomandibular joints. Now, when it becomes the temporomandibular joint arthropathy, it could be because of the degenerative arthritis, it could be because of the inflammatory arthritis, or sometimes it could be post-traumatic or infective arthritis. But remember, far more common, it has been found because of the bruxism or the jaw grinding, or sometimes with the jaw trauma, dental malocclusion, systemic inflammatory disorders, stress. In fact, in some persons, they having the bruxism while having the stress, and that can cause this type of complications. In fact, in one of the neurosurgeons, I got this type of conditions, and ultimately I have to do twice the injection in the temporomandibular joint. Finally, the surgeon was very good after that. Now, coming to the symptoms and clinical signs. So basically here it's the pain in the jaw, ear, temples, and the joint. Sometimes could be a clicking or popping noise, and there is a limited jaw opening. Sometimes there could be jaw locking. Sometimes it can cause headache or ear fullness, and sometimes that can cause chewing difficulty as well. Examination will reveal tenderness at this point, but remember, the nature of pain is usually different. Here the tenderness is mainly nociceptive, not an electric shock like feeling, with contrast with the trigeminal neuralgia. Sometimes there could be crepitus while we are palpating it, and there could be deviation and opening, and there could be muscle spasm as well. A clinical evaluation includes the inspection, palpation, and the range of motion assessment, and imaging. Mostly we do the ultrasound nowadays, and definitely MRI can show you the disc position and effusion if present, and CT scan can show joint effusion. But ultimately, as in our clinic, we have the ultrasound, so we usually do for the ultrasound evaluation first. And in the management part, first part is definitely conservative, so usually we give rest, sometimes we give some NSAID, we do some stress management and avoiding the wide mouth opening at the initial present. Sometimes there could be occlusive splints can be given. Physical therapy, muscle stretching exercise and can be possible, but in most of the cases we go for the NSAIDs and the muscle relaxant, and sometimes tricyclic antidepressants for if the pain is very chronic. So once we have given and it is not responding, then we can go for the intra-articular corticosteroid injection for the inflammation. Hyaluronic acid for lubrication is also done in certain studies, and sometimes the PRP therapy for regeneration is also tried. Arthrostensis and the lavage of the joint and has also been tried, but sometimes, yes, true, it can be a little bit difficult and challenging, and ultimately in few cases there could be possibly arthroscopy can be done for the adhesiolysis and repositioning. Now, surgical management is revised for the refractory cases. It includes the disc repositioning, removal, sometimes condylectomy, TMJ replacement. But remember, usually we don't have to go to that spectrum in most of the cases. In most of the cases, actually, you can go for the conservative management. It responds very well. And if not, you can go for the injections. Now, newer therapies includes the injection of the botulinum toxins for the muscle spasms, and low-level laser therapy and TENS for the pain relief, cognitive behavioral therapy for TMTA-related disorders. Remember, in a number of cases, it causes a huge psychological impact as well, and multimodal modal approach has been found to be the best in case of chronic cases. And sometimes daily, it is a little bit difficult. Prognosis and follow-up, majority of the patient improve with the non-surgical management. Long-term follow-up may be necessary for the inflammatory or chronic degenerative condition. Early diagnosis and the patient compliance is the main key, and multidisciplinary care definitely improves the outcome. So in summary, TMJ arthrosis is a multifactorial joint disorder, sometimes may be associated with the other causes of facial pain, but its main management is conservative, and sometimes it could require some interventional management, and if it is not responding, surgery can be done, but in most of the cases the conservative and the interventional management gives a very good result, and most of the cases the result is good. So that is how we have to go for the TMJ injection. Simply we usually first locate the TMJ and then we usually take out of plane approach. Again, it's a very superficial joint, so going in plane is sometimes difficult. We go out of plane and we inject within the joint. So that is a simple way. Previously we have done a number of cases with blind also. We just palpated the TMJ and then put the needle inside the TMJ, and usually 0.5 to 1 ml steroid and local anesthetic is usually injected and we come out. So this is one of the very simple procedure but very effective procedure in a number of cases. So basically TMJ injection, I am stressing this much because in a number of cases it could be associated with the trigeminal neuralgia, and even after blocking the trigeminal Gargassian ganglion we have to go for the TMJ intervention later if both are present together. Okay, so any questions? If there are no questions, then we will be going for the quiz.com. Okay, so those who are new, just I am requesting everyone to please go for the where is it? Just 1 second. Now, okay. Please open quiz.com and then input this pin. You don't have to put your name. It will take name, anonymous names. If you want, you can change it, but it is not necessary. And requesting all please to join.
Unknown. Unlucky Random Heist. Wasp. Uncle Dr. Woman. Nut. Quick Slow.
Requesting all to please join. If you give a wrong answer, it doesn't matter, but please join because this is basically a test for yourself, how much you have learned.
Fair student.
It's very simple. Anyone want to join? Waiting for it, then I will wait, otherwise I will start. Okay, no one wants to join more.
Quiz.com. Play and create.
Which division of the
Dr. Boat
trigeminal nerve
joined.
is most commonly involved in trigeminal neuralgia? V2 plus V3.
It's approximately 32% of the cases, both V2 and V3 together are involved.
What is the characteristic nature of trigeminal neuralgia pain? Agonizing, paroxysmal, and lancinating.
Yes, it is an electric shock-like pain and agonizing definitely.
Which medication is considered first line in the treatment of trigeminal neuralgia?
This is the simplest UG question. I hope everyone will give a correct answer.
Carbamazepine.
Jolly aimbot joined.
Which of the following is not an interventional option for trigeminal neuralgia? Intra-articular steroid injection. What is a red flag suggesting secondary trigeminal neuralgia? Features suggestive of CP angle tumor. Supraorbial nerve is a branch of which division of the trigeminal nerve? Ophthalmic. Which artery is visualized in ultrasound-guided maxillary nerve block? Internal maxillary artery. Which foramen is targeted during infraorbital nerve block?
Another very simple question.
Infraorbital foramen. What is the most common symptom of TMJ arthropathy? Pain in jaw, ear, or temples. Which imaging modality best visualizes TMJ disc position and diffusion? MRI.
Final question. Double points.
Which is an emerging adjunct therapy in chronic TMT? D. All of the above.
Third place. Dr. Boat. Second place. Quick Slow. And the winner is unknown.
Okay, where is the unknown today? So there was a close fight today between the quick, slow, and the unknown. So who is the unknown today?
Me, Te.
Okay, congratulations. You scored the maximum for today. So we have already started the MCQs in the app, as well as we have already given an audio podcast for you, and this class recording will be recorded, will be given tomorrow. Okay, if you have any questions, you can put in our WhatsApp. Okay, so let's end today.